My name is Dave Walden. For those of you who don't know, I am an associate professor here at the University of Western Ontario in London, Ontario, Canada. And I also work through my own personal business, providing what we think are good quality professional development courses for clinicians. I'm joined today by one of our newest instructors for an upcoming session called the Swales Performance System. And in fact, I am joined by Tom Swales himself. Tom, welcome.
Thanks, Dave. Thanks for having me.
Absolutely. And Tom, this is a brand new course. I think people are kind of excited. It's something we've heard a lot from clinicians, is that there's not a lot of opportunity to develop those good high-level exercise instructional skills. And I know that's what you're bringing to the professional development landscape in Barrie in September.
Yep.
So really, I just want to have an opportunity for people to get to know you a little bit and hear a little bit about your background and what they can expect to learn. So first of all, I know that we've known each other for several years now. You came to our MPT training program here at Western when I was one of the instructors. I still am. And more recently, you've gone through our teaching development workshop as a post-professional education to develop your own teaching skills and course design skills. But I know you've done a lot else in your background. You've got a lot of letters after your name. Can you tell us a bit about what you've done and what your training entails?
Yeah, so started out, so before physio school, I went down to the States on a soccer scholarship. I got my athletic training certification down there, which is a 4-year bachelor's, working with on-field athletes in the clinic. So I kind of got my athletic orthopedic skill set starting from that point. From there on, I went, did strength conditioning, personal training, and then, so that was about 2 years. So I got some real world life experience and application with it, with regards to training clients, training athletes, and even training myself. And then for those 2 years, after those 2 years, I got into the MPT program at Western, where I had the privilege of you being one of my professors. And actually, I believe you gave me my first nickname there. What was it? Guns McGee or something like that?
And I think we called you Guns, yeah.
Yeah,
right.
yeah.
You had arms larger than my legs at the time.
Yeah, so that stuck nicely. So that was a good first impression for all my classmates. But so yeah, then after doing that, I worked with the Canadian Alpine Ski Team for a few years as a physio strength coach. Learned a lot with regards to, again, like quick on-field stuff and triage and, just working with those high caliber athletes. From there, I got to work with a good friend and mentor of mine, Doug Freer, for X number of years, learned how to be a really good clinician, empathizing with patients, learning how the body, whole mind, body, spirit works together. And then my wife and I, we opened up our own facility here in Barrie, and it's an amalgamation of strength conditioning, movement performance, movement therapy with manual therapy. So I've kind of melded all those philosophies together into kind of our own system here.
Great. Yeah, geez, Doug Freer is a bit of a local legend, isn't he? It's awful nice to have had the opportunity to learn from him.
Yeah, it was great. He's the man.
Yeah, fantastic. Okay, so this being the first time that the course has been offered sort of more widely, I know people probably have some questions about what they're going to learn on the course, how it will be different from some of the courses that they can take through other more traditional avenues, at least here in Canada. So tell us a little bit about what people can expect to learn if they take the Swales Performance System course.
So I think we need to first look at where there might be a problem in the system of kind of corrective exercises, rehabilitation. So, taking on students every year coming from, MPT programs or MSc programs, they're coming in with these very arbitrary exercises for rehabbing hips and core and trying to consciously, all right, fire your TA. Like they're teaching a lot of exercises that don't really apply very well clinically. Rotator cuff exercises, rotation with bands. That's not really how the rotator cuff works. So I started looking at, well, how can we put together a system that both will work with clients from an acute stage, a very low level functioning, that is scalable and progressive to get them up to a very high level functioning using significant loads, significant weights, using their body weight, using various tools such as kettlebells and Olympic rings and barbells. Because, for example, if I've got a firefighter who tweaks their neck, them lifting their hose in their profession can weigh up to 500 pounds charged. They need to lift significant loads from the floor to their shoulder to overhead. So a kind of a traditional or traditional mindset of treating an acute neck, but not load up the neck or load up the body, it's just going to come back. So that's where I come up with this this progressive system, and it's looking at how the body kind of, how is a neck related to a hip? How is a neck related to my foot? It's really a holistic approach on how everything is integrated. It's really that it uses a neurodevelopmental model, and then building upon that, more of a performance and movement strategy on how to advance those patterns.
Yeah, geez, that's fascinating, Tom. So, I mean, I'm thinking of how you've taken your background both in strength and conditioning and in some of the sports therapy, and now, more recently in physiotherapy. And one of the thoughts I've got, and certainly a question, at least one question that I've fielded, is that it sounds as though you are proposing far higher intensity of exercise than what many of us will have learned in our training programs.
Much higher.
Fair to say?
Yeah, because loads can actually teach you how to function. When you've got a moderate amount of load, if the load isn't enough, it's not going to be enough of a stimulus to actually elicit a proper pattern or response. If the load's too much, you're going to buckle or crumble on it, and you're going to use compensation. So it's dosing and finding the right amount of loads to actually create a learning response through the motor system, and not actually touch into fatigue.
So that makes sense. What would you say to somebody who's concerned that the level of exercise you're teaching is too high for their sort of routine, community clinical practice out on the corner?
So I asked people, I said, well, do you pick things up off the ground? How heavy is your grandchild? How heavy is your purse? So if you've got a 40-pound grandchild and you're bending over, you're doing a deadlift. So you're at least going to be picking up a 40 or 50-pound kettlebell, because functionally that carries over to picking up your grandchild without throwing your back out. And if you know how to set the grip, the shoulders, ground the feet, corkscrew those hips in, and make sure, I think you have to put it into how is this clinically applicable to my patients, and then really explaining it to them first. Because everyone's like, well, deadlifting's a powerlifting exercise. No, it's a functional exercise, and it's the first lift that we did as a child. So you watch any of our kids, they squat fully deeply, but if they pick up something that's significantly heavy, they'll lift their hips and they hip hinge. That's a deadlift. So it's really one of the first lifts that we eventually do. Yeah,
I love what you're saying there as far as, we should probably be pushing people a lot harder than we traditionally do. I think, and I know I'm painting people with very broad strokes here, but, physio-wise, I think we've always been a little bit, we've erred more on the side of caution, I suppose, when it comes to strengthening exercise. And I'll share a really quick story with you. I was out west as part of the Physio Moves Canada project here just recently, and had time to spend with a clinician who runs boxing classes for patients with Parkinson's disease.
Yep.
And, that was just, again, another perfect example. I mean, she's got these 60, 70, 80-year-old clients, males and females, strapping on boxing gloves and hitting the bag. Certainly not something that I would have learned to do as a student, right? We were taught to be, I think, more cautious than that. So really nice to hear that what you're trying to do is encourage people to really look at what do we actually do on a routine daily basis.
Yeah.
And it turns out we probably do a lot more than what our physio exercises are actually preparing us for. So that's very cool. So we might have already answered this question, but if I was to say then, how is what somebody's going to learn in your course different from what they might learn in a standard, the standard rehab courses, say, that you've done in the past?
Yeah. So it's really an accumulation. I've done a lot of different movement systems. I've trained, through functional movement systems. I've trained through natural movement systems, kettlebells, powerlifting, Olympic lifting, gymnastics. And what I've done is I've made it scalable that you can use a lot of the tools. These are fantastic movement systems. Yoga is a big component that we use. We pair up mobility with strength all the time. But what I found is, I look at these entry-level strength mobility exercises from each of these disciplines, and I put them and I've streamlined them. Like, these are the best ones that are going to get the biggest bang for your buck. Let's put these into kind of a level one, and how to stream them together, how to link them together. So, we get somebody to crawl, then we open up the hips, and then we go deadlift something, and then we walk across a balance beam carrying onto a kettlebell. So we work multiple systems, and we stimulate the brain and the body in various ways. So it's stacking movements on top of one another, rather than, well, let's just do this, 2 to 5 times, put it down, stand around. Like,
Right.
That's
The old three
fine,
sets
but
of 10 sort of thing.
from a real world perspective, I'm like, you're going to pick something up. You're probably going to carry it over here. Then you might have to get on the floor to do something with your children. Then you might have to get up off the floor and go make dinner. Like,
Right.
there's all these multiple patterns. So, a lot of the various systems, I find it's too one-dimensional. And the more three-dimensional you can get the brain to work and get people to really think about how they're transitioning. So it's not just get up off the floor. How did you do that?
Mm-hmm.
What pattern did you use? What muscles were you working? And when you're feeling out the movements and you're feeling what muscles are working, that's really where the mind-body connection comes in. And that's where the learning comes in. People are, they go out, they're like, I'm just going to go for a run and just turn everything off. Listen to music and just shut down. They come in the next day, well, I tweaked my knee running. Well, were you paying attention to what you were doing? Like, that's the time you should be paying the most attention to your body and how it feels, not to shut everything up. You shut out the world, fine. But it's time to kind of be mindful of what you're doing and start to retrain your brain on how to move again.
Geez, I love the concept of just mindfulness in everyday life. And it's really kind of neat for me to hear that you're trying to bring some of that mind-body connection into exercise and rehab science. And I'm also definitely hearing, as you mentioned already, a real strong thrust of neurodevelopmental understanding, neurophysiology, and it sounds like you're getting at the neuroplastic change as well that comes along with motor training.
Oh, yeah.
So that's all great. This sounds like it's well researched. Now, I know you did do the teaching development course, as I alluded to earlier. Now, the reason I want to bring this up, and I don't mind being transparent about this, is that this is something that I truly believe in. Is there are a lot of professional development opportunities out there for clinicians to spend their time and their money on, and certainly, with all due respect to many of our colleagues who do teach these, very few have had the opportunity to actually spend time developing their teaching skills. And I know that's one thing that you did, and you came through a course that myself and Jackie Sadie taught here in London. Can you just tell me a bit about how the process, how the experience of going through that teaching development course has influenced the way you've put this course together?
Yeah, so, having done a few workshops and, kind of self-reflecting, it's not the same as getting feedback from your peers, feedback from your instructors, what you could do differently, PowerPoint. It was a big eye-opener, and, the amount of research that you guys put into this and looking at the best ways to teach certain types of learners and finding out what your students want to learn and versus how they learn. That was critical. It comes back to, I've always learned that everyone moves a little bit different. So I took that principle of everyone's a little individual, unique, beautiful snowflake, and you have to approach them that way. That's a little quote from my friend Max. But you have to approach everybody individually, your patients versus your students. And just listening to, asking good questions to your students, you get an idea of how they want to learn and what they want to learn and the particular style. So I found that one of the most useful components of your course, on top of how to keep people engaged, and then even a different perspective of if somebody's disengaged from your course, you don't know why, right? Mm-hmm. My immediate response, I'm like, well, they don't want to be here, but they might have some family issues, or they might be getting married, and we don't know why, right? So that brought a better understanding and empathy from myself as an instructor to student and vice versa. But like you said, there's a lot of really, really smart people out there, but to communicate the ideas and the information in a very engaging way, there's some influencers and people that I love follow. I just love listening to them. They're great speakers, and they have really good information. They're not going to bombard you with information, but they're giving you just enough and exactly what you need to or want to hear.
Right.
So, just like right now, I am rambling. So from your course, I got to learn to kind of cut that down, not deviate from
self-awareness. There we go.
Cool idea. Let's bring this in. No, let's just stay on
demonstrating track. In real time, Tom. Self-awareness.
Yeah, I know.
Yeah, so, and I know there was a real emphasis on transformative learning, right? We want to make sure that what people are learning actually leads to a change in clinical behaviors. And maybe that's the last question I'll ask you then is how can people expect their practice to change as a result of taking your course?
Yeah, so people are gonna go in because the first part of the first day is movement assessment, biomechanics, length, muscle. They're gonna learn to look at the patient differently, not just I have elbow pain. Okay, well, what relates to the elbow? Well, how's their grip strength? How's their wrist mobility? How's that shoulder work? They're gonna look at the body from a global perspective and then narrow down their orthopedic assessment into, okay, yeah, like these are the diagnosed tissues that are at fault, but let's not chase pain. Let's not focus on pain. Let's look at what's not moving. Let's see what's really deficient in the body. Go after the most dysfunctional, tightest part of the body first. Work on that and then see how it integrates back into the painful site. So it's going to give people a different framework to work off of, a different approach to add corrective exercise. And at the end of the day, they're going to get a different outcome. I'll use an example of an ACL reconstruction. Post-op, day 2. What are you going to do with them? Okay, yeah, you can do some quad activation, but what else needs to be fixed? Well, go after their core, right? Get their glutes firing up. Go after some slings because that needs to be fixed because they've been limping for the last couple of days, so they've altered their movement pattern. So reset the spine. So yeah, do your manual therapy on the knee. Get the swelling down, get it moving, do your mobilizations, but don't just chase after quads and hamstring activation. Go after those glutes, go after the core, go after the spine, go after neck reflexes, eye training. We're going to do some, a little bit of juggling to get saccadic eye training and see how it plays off with the cerebellum and then the whole motor system. So they're going to learn that I don't have to just focus on the painful spot. I need to fix a bunch of other stuff too to get that optimal.
Right. Geez, and I think that's a good message because you're quite right. It's easy, especially for novice clinicians, I find, to go into a clinical encounter and say, okay, this is a knee problem, this is a back problem, and immediately this patient who's a real live person living and functioning in a real live world gets reduced to sort of an L4-5 or a tibiofemoral joint. So certainly I think the idea of opening it up and looking more holistically is going to be key.
Yeah.
Tom, this is great. I mean, one thing I have to say that I love about you, and something that I've always been impressed with, is that you really do practice what you preach. And I know that if people want to see evidence of that, you've got a fairly strong internet footprint. You're not trying to hide anything that you do. So tell us, where can people find more? You've got a YouTube channel.
Yeah, so YouTube is Tom Swales 13.
Tom Swales 13.
I'll post performance corrective stuff up there, rehabilitation. So it's going to be a mix from here's how you fix or go at. I just posted a tight calf video sequence on how to go after that, into some higher performance stuff to, it kind of express to people like, by having a systematic view of your training and rehabilitation, you can get to higher levels of performance if that's your goal. So it's both ends of the spectrum. My Instagram is also Tom Swales 13. Twitter, Concept of Movement is our main website right now.
Right.
And so you can reach me there, and the workshops are all posted up on that. That'll link up to yours, and yeah.
Yeah, no, absolutely. I mean, if you want to see Tom without a shirt, then you can certainly jump onto his Instagram account. The man's not shy about sharing what God gave him. But no, that's not what he's worked very hard to achieve.
I gotta get my vitamin D. So
there you go. Fantastic. All right. Well, listen, if people are keen to get on your course, Tom, I'm super excited about it. I love that we're bringing someone like you, very dynamic, but also someone who sort of just walks the walk, doesn't just talk the talk, to the landscape here in physio. I feel like we're introducing something new and different and unique, which is high-level exercise and a real strong sort of a science-based or an evidence, at least grounded approach to prescribing exercise. So I'm really excited about that. People who are interested, you can head over to pearlresearch.com. That's PIRL research.com. And we've got a courses link there that you can register through. Tom, thank you very much for joining me today. That's fantastic.
Awesome.
And,
all right, Dave.
Signing off.
Thank you.